Hi, Milind. How are you?
Good, good. And you?
All fine, all fine. Just finished our M&M meeting and I managed to get home before the meeting starts.
Oh, good, good, good.
I just want to stop my fancy background.
No, you can keep it. It looks wonderful.
Yeah, but I don't have hair, you see.
it just shows your the wind is blowing your hair.
It doesn't look good. I see we've been recorded as well.
Yes, yes.
Before I start, I just want to confirm that I'm being heard clearly.
Yeah, it's nice and clear, Vuyo. Thank you.
All right. I'm presenting on upper gastrointestinal bleeding in adults as well as children. Okay. I'm having problems moving to the next slide.
Okay, we'll just wait, Vuyo. No issues.
Okay.
You may have to shut down the presentation and start again.
Gastrointestinal bleeding is a potentially life-threatening abdominal emergency. Gastrointestinal bleeding as a whole is divided into upper versus lower gastrointestinal bleeding. So the upper is any bleeding that is derived from a source proximal to the ligament of Treitz, which correlates anatomically up until the proximal 2/3 of the duodenum. So this is basically an approach to upper gastrointestinal bleeding. A patient who presents with upper gastrointestinal bleeding, you start with the initial patient evaluation. You need to get information about the characteristics of the bleeding. If there was hematemesis, any presence of melena stools, hematochezia, and also find out about any associated symptoms. History of NSAID use and salicylate use is also very important in the history, as well as the different things that you can ask in the past medical history that I've mentioned here.
Yeah.
So this is just to give you clues in the initial patient evaluation as to what might be the cause of the patient's bleeding. So, for example, in Mallory-Weiss tears, it's usually associated with multiple episodes of emesis before the patient actually has hematemesis, also has retching as well, and there's also a strong history of alcoholism in some of these patients. Peptic ulcers as well, you get patients with epigastric pain, NSAID or salicylate use, etc. When it comes to physical examination, you need to determine the degree of blood loss and volume depletion. This is by basically monitoring the vitals of the patient. If the patient, assessing whether the patient is in shock, yeah. You need to examine the oropharynx and the nose. Some of the patients who present as upper gastrointestinal bleeding might have a bleeding source that is in the oropharynx or the nose, and they end up swallowing the blood, and it might be incorrectly assessed as an upper GI bleed. Inspection, you might find signs of liver failure in these patients. And also, when it comes to palpation and percussion, some of these patients might have hepatosplenomegaly ascites. Important in the physical examination is a rectal examination, where you assess the quality of the stool, whether it's a melinous stool, whether there is frank blood in the stool. Those are important in the assessment. After you've done your physical examination, you need to do some lab investigations, which include hemoglobin, hematocrit, coagulation profile, liver function test, serum electrolytes, renal function, and also you might need to do a type and a cross match for these patients, anticipating resuscitation. With resuscitation, you need to put in 2 large bore IV lines and also a urinary catheter, Foley's catheter, to monitor the urine output as you continue with your resuscitation. Some of these patients might present mentally obtunded or having massive hematemesis, which might put them at a risk of aspiration. So in order to protect the airway, you need to assess whether you need to intubate the patient. Nasogastric tube will help you in terms of assessing the gastric contents. So in some patients, you might find some coffee ground aspirates. And in some patients, particularly with massive hematemesis, you might find some frank blood. It's also beneficial later, especially in patients with variceal associated upper GI bleeds, that later you might need to do a gastric lavage in order to be able to see clearly when you're doing an endoscopy. As the patient continues to bleed, you also need to continuously resuscitate your patient with crystalloids as well as blood transfusion. As I mentioned in the previous slide, that you need to do a coagulation profile. You need to correct any coagulation defects accordingly. So the INR and the PTT, as well as the platelets, are important in order to know what you are correcting. There are some adverse prognostic factors that have been described. These are based on information that I received about the different risk scoring systems that are used for patients with upper GI bleeding, as mentioned below in bold. The Blatchford score, the Rockwell score, and there's also a bleed risk stratification scheme. All these are basically, they have these components in them that basically help you to assess the prognosis of your patient. The Blatchford score is particularly important in an emergency setting because the parameters that are assessed there don't include endoscopic findings. So it helps you to assess whether you can safely discharge a patient that had presented with an upper GI bleed, or you need to observe or do any further management. The Rockwell score as well, but it also includes endoscopic findings. There is a pre-endoscopic Rockwell score that's been described as well that doesn't have the endoscopic findings as part of the assessment. So all these are basically what you can, it shows your patient's prognosis. All right, after patient, while basically you're still resuscitating your patient, you need to keep in mind that you need to identify the source of the bleeding. Patients who are hemodynamically unstable and have signs of ongoing hemorrhage will need an emergency upper GI endoscopy within 2 hours. So, yeah, and patients who are stable, no signs of ongoing hemorrhage, you can do the endoscopy within 12 hours while closely observing the patient. Some texts even say up to 24 hours, but it depends on the clinical status of the patient. As far as the cause, the different causes of upper GI bleeds, these are the ones that I am gonna mention, and the ones in bold are the most common ones. And this is for adults. And then when it comes to pediatrics, neonates, the most common ones are the ones that I've mentioned in bold. Coagulopathy, as well as stress gastritis or ulcers, might also be more common in children, in neonates. And then in infants and toddlers, peptic ulcer, variceal bleeding, and reflux esophagitis. And then in older children, it's very similar to what we find in adults. Yeah. Oh, sorry. Okay, this is just an image showing the different, the different causes as well as their percentage in terms of causing upper GI bleeds. Peptic ulcer being the most common in adults, with 35 to 50%. That gastric and duodenal ulcers each contribute about 25% to the causes of upper GI bleeding in adults. A bleeding peptic ulcer is the most common cause in adults for upper GI bleeding. And important in the pathogenesis is Helicobacter pylori, which contributes 40 to 50% in the etiology, as well as NSAIDs, 40%. The less common gastrin secreting tumors, like the Zollinger-Ellison syndrome, it's about 1 to 2%. So this is the Forrest Classification for ulcers on endoscopy. So it's helpful in determining the risk of rebleeding in these patients. So a patient who has a Forrest classification of 1A has a 90 to 100% risk of rebleeding, which is a poor prognostic factor as compared to Forrest classification 3, which is a clean ulcer base that rarely bleeds. This is just an image showing the different and how it would look endoscopically when you're looking at the ulcer. The one in 1A, you can see this arterial jet, yeah, and the different other grades in the classification. So with the peptic ulcers, medical management includes stopping NSAIDs, administration of H2 receptor antagonists or proton pump inhibitors, as well as Helicobacter pylori and eradication. Most of these patients, actually, it's advised that a follow-up endoscopy should be done in 4 to 6 weeks. Endoscopic therapy while doing the endoscopy includes injection or thermal therapy. So depending on the surgeon's expertise, they can choose to do sclerosing agent or laser therapy. But sclerosing therapy is the one that is most often used in most centers. Surgical therapy is indicated in patients who have basically active bleeding and also significant recurrent hemorrhage or have ongoing transfusion requirements. The recommended H.Pylori eradication therapy in children includes first and second line therapy. First line therapy is 1 PPI and 2 antibiotics for 10 to 14 days. And second line is prolonged to 14 days with the addition of bismuth. And then on the second part there, you can use a H2 receptor antagonist like ranitidine. I'll quickly go through the other causes. The reason why I added this acute gastric mucosal lesions is because they're quite common in critically ill patients, and that these patients, as I mentioned here, there's particular risk factors that predispose these patients to these lesions. So any patient who has any of these risk factors should be put on prophylaxis to avoid having to go into endoscopy and requiring endoscopic therapy. And also surgery for this patient is not often feasible because they're usually critically ill and are anesthetic risk. And then Mallory-Weiss tears. For these patients also, the tears themselves, the hematemesis, I would say, is usually self-limiting. But if there's anything that needs to be done, it can be achieved by endoscopy and endoscopic therapy. Any rebleeding from these tears may be related to ongoing or uncorrected coagulopathy. So it's important to know the coagulation profile of your patient. Other causes, there may be esophageal sources, infectious causes, reflux, Barrett's epithelium malignancy. One worth mentioning as far as infectious is that immunocompromised patients with HIV might be at risk of having esophagitis. And also for children, another esophagitis that is worth mentioning is the eosinophilic esophagitis, which was first described in children, but it also occurs in adults. It's not well understood, but food allergy may play a role in the pathogenesis of this condition. But regardless, it's one of the things we need to think about when you have a child who has esophagitis and you're not too clear on the cause. And then the other causes, as I have mentioned. So on the management algorithm, I've already mentioned most of what is here. So basically, it's just to highlight that the initial management is by endoscopy plus endoscopic therapy. And if that fails, then you can consider taking the patient to theater. And then portal hypertension related upper GI bleeding is the bleeding from the esophagogastric varices is responsible for 1/3 of all deaths in patients with cirrhosis and portal hypertension. So the mortality risk from each episode is about 25%. And intervention is by endoscopic therapy, which is sclerotherapy or rubber band ligation. You might also need to give concomitant treatment with vasoactive drugs like octreotide. The octreotide is a somatostatin analog, which basically decreases splanchnic blood flow, decreasing portal and variceal pressure. So combination of endoscopic therapy and octreotide is said to stop bleeding in about 80 to 90% of cases. If sclerotherapy is ineffective, then a temporizing measure can be used to stop the bleeding, like the Sengstaken-Blakemore Tube. There are other similar tubes available, like the Minnesota or the Linton-Nicholas tube. So the management algorithm for variceal bleeding, I would say. So any patient with bleeding esophageal varices, the emergency sclerotherapy is the first line. If the bleeding persists or recurs, you can repeat the sclerotherapy. And then if the bleeding persists, then you can do, as I mentioned, the balloon tamponade for temporary control. And then and then other things that can be done for these patients in order to relieve pressure on the portal system is basically through shunting. So the different options that I mentioned here, with an aim to do a liver transplant in patients who are candidates. And then similar for the bleeding gastric varices. Just an image on the varices, the rubber band ligation, and what it actually looks like endoscopically. And this is the Sengstaken-Blakemore Tube. It has 3 ports, the gastric balloon port, esophageal balloon port, and the gastric aspiration port. So it needs to be put in orally, and you need to be careful to avoid esophageal perforation or rupture with this. So the first, and also once you've inserted the tube, in order to stop the bleeding, you need to inflate the gastric balloon, which puts pressure on the esophagogastric junction, the varices that are there, and most of the time it stops the bleeding. But if the bleeding doesn't stop, then you can put in inflate the esophageal balloon. The gastric aspiration port just helps you to aspirate gastric contents. And importantly, it needs to be weighted, 250 to 500 gram weight. And as I said, it's a temporary measure. It should not be put in for more than 24 hours in a patient, as it has its own complications. And then prevention, I just thought to include this because most of the in upper GI bleed, we have several opportunities to prevent the upper GI bleed in the first place. So there's primary prevention as well as secondary prevention. So proton pump inhibitors in patients taking therapy, in patients taking NSAIDs might help to prevent upper GI bleeds. Helicobacter pylori eradication is one, as well as prophylactic PPI therapy in patients with physiologic stress. Those are the patients who are critically ill and might be at risk of having those gastric mucosal lesions. And then secondary prevention, PPI therapy in patients with peptic ulcer disease, there's a reduced risk of rebleeding, as well as IV octreotide therapy reduces esophageal variceal bleeding. So my conclusion in this whole talk is that what is important as in management of a patient with an upper GI bleed is basically based on this approach. It's not as important to identify the source of bleeding as it is to stabilize the patient. So the immediate initial assessment and the initial resuscitation plays a huge role in the morbidity and the mortality of the patient. So we should keep that in mind. And the management, the initial management in all these patients is the same. They also mentioned that in adults, especially the adults over 60, the mortality is not associated more with the source of bleeding, but rather with the repeated episodes of shock, as well as the resulting multi-organ dysfunction. So yeah, that's all. Thank you.
Uyo, that was a really excellent presentation. It was really a huge topic, especially including adults and children. And don't worry about the technical difficulties. All of us face technical difficulties during web presentations. So it was very good. I learned a lot myself because obviously I haven't read about adult problems in the recent past, and so well done. So I'll now just request Professor Alp to give his comments and his advice about this vast topic. Alp?
Thank you very much, Milind. And well, firstly, thank you very much for a very nice introduction. And I just want to be known as Alp, and that's more than enough for me. But thank you. In the process, you've also mentioned that I've been at Red Cross for many years, and I have to say that I think the last adult patient that came in with upper GI bleeding that I saw must have been about probably 25 years ago, and I don't really miss it, I have to say. But we are talked very nicely, and she presented very nicely. And as you also mentioned, it is a vast topic. And I think if you mix adult and children together, the differential diagnosis is massive. And we all know, I mean, in adults, it's sort of the alcoholic cirrhosis related esophageal varices, and bleeding from that is quite common. That's probably one of the main presentations to an emergency center, and everything that we are highlighted in terms of immediate management and emergency management is very much applicable. And then the other group is the peptic ulcers. And so I have to compare what happened 25 years ago and what's happening now, and certainly in the past, particularly with the peptic ulcer disease in adults. Firstly, we would think if it's a bleeding ulcer or is a perforation, we sort of anatomically place the duodenal ulcer where it might be. And if it's a bleeding one, of course, we would think a more posteriorly placed ulcer and eroded into the gastroduodenal artery. And if you can stop it with injection sclerotherapy type of thing, or injection and endoscopic way, it's great. But it's not always easy. And there's a lot of blood coming out, and you may not have the facilities to do that. And we still need to keep in mind the old surgery. So doing a laparotomy and opening the anterior wall of duodenum and putting one stitch to that ulcer might be life-saving. But that's all I want to talk about it, because I'm not really involved in the adult upper GI bleeding management anymore, really. With regards to the children, I think you highlighted very nicely, Vuyo. I mean, you've put down the different ages and what the potential causes might be. Perhaps comparing with adults again, I can say that the management might be slightly different. The emergency management might be slightly different. Certainly the emergency endoscopy is not that commonly used in children. We tend to stabilize them, admit them to ICU, make sure that the coagulation is checked, and then looking at potential underlying causes. And I'll touch a little bit now about, of course, the liver disease is one of the main ones. But the octreotide and so on, with portal hypertension, those are the things that we would use, perhaps with a Sengstaken tube as well. But then the endoscopy comes in when the patient is a little bit more stable, which is different to the adult management. In adults, you would take them to theater or under sedation, of course, and you would try to inject the varices. That's if that is the cause for bleeding, or identify the bleeding ulcer. So perhaps we can make a slight differentiation there. And I'm just thinking in children, what do we see? What we see in our normal practice here, and the sort of the seldom ones, the Mallory-Weiss tears, we certainly see them, but it's not that common. A very typical history: vomiting first, extensive vomiting, and then the hematemesis that comes follows, and can be significant bleeding, but they're seldom life-threatening. Gastritis and ulcers also certainly seen in children too. We need to keep them in mind in terms of causes for upper GI bleeding and significant upper GI bleeding. But really, the practice that we have is mainly liver disease related, and maybe because we do get the Kasai and failed Kasais and liver end-stage liver disease patients often, but that is sort of one big group that comes through our way. And then the other group is again portal hypertension, but not associated with the liver disease. So when we think about it, the facial varices is probably the most common significant severe upper GI bleeding cause for us in our sort of normal daily practice. And then it is probably better to just divide them into the two groups, whether it's associated with the cirrhosis or end-stage liver disease, whether it's associated with the extrahepatic portal hypertension. In terms of their management, the banding is certainly something that's been utilized commonly. If you want to eradicate the varices or try to control them. Injection sclerotherapy of varices has also been used a lot. Perhaps injection of the varices with sclerotherapy was in the earlier years, and John Terblanche has popularized it quite a lot from the general surgery side. And then the person who developed the banding, I believe he was one of his overseas fellows here. And again, this must have been whatever 30, 35 years, maybe 40 years ago. And he mentioned the banding to John Terblanche, and John Terblanche felt, this is something that's never going to materialize. And when he was giving his retirement speech, he talked about two things that he thought it's not gonna really fly. One of them was the banding, and he said the other thing was the laparoscopic cholecystectomy. And he was wrong in both of them. And it's amazing how banding has become popular now. And, a more commonly used, particularly if the child is more than 6 months of age, and you can get the banding device in. And then, of course, the ultimate treatment would be in the end-stage liver disease is to do the liver transplantation for them. The other big group is, well, perhaps not massive, but significant group that we've been dealing with is the extrahepatic portal hypertension, which is when the extrahepatic portal vein is occluded, and there are many reasons for that as well, of course. But the liver function is normal, and the liver anatomy is normal, and liver histology is normal. Sometimes they might have a mild raised INR, but not really too significant. And the usual emergency sort of management of the varices that takes place, and they present multiple times with upper GI bleeding due to the varices bleeding. And but of course, as a definitive treatment, one needs to address the problem, and using the mesoportal bypass or the Rex shunt by taking the internal jugular vein and using it as a bypass from the superior mesenteric vein and the Rex vein, which is also the part of the left portal system. By creating that bypass, you're able to bypass the extrahepatic portal system, and it immediately resolves the portal hypertension, and that's that's obviously a cure for the bleeding from the portal hypertension related as a varices. So Milan, these are sort of the things that comes to my mind now as I've seen the presentation, and then when I think about our practice here. If there are any other comments or any other questions, we can certainly discuss them, and then we can take it further from there.
Yes. No, thank you. Thank you very much, Al. That's quite useful. And I'm glad you mentioned about Professor John Trelbranche. Some of the junior doctors may not know him. He was the head of general surgery and probably gastroenterology at Prognostic Hospital in the late 70s and 80s. And just historically, it is important for us to know that he popularized the endoscopic sclerotherapy for bleeding esophageal varices. And yeah, thank you for pointing out the differences between adults and children, and in children also one with end-stage liver disease and one without liver disease. And I'm also glad that Vuyo mentioned about the cause of esophagitis, which we all pediatric surgeons like to ask, the eosinophilic esophagitis. So what I will do is now I will invite one after the other our consultant pediatric surgeons. And first I will invite Dr. Selo Machaya, who has mentored Dr. Nogela for this talk, but he is actually also helping her to prepare for the intermediate examination. And he is our de facto hepatobiliary GI pediatric surgeon. So Selo, please comment.
Hi, thanks, Prof. Thanks, Prof. Alp, for joining us. Very good talk, Vuyo. I think the important thing to get out of everything Vuyo has said today is when anyone presents with an upper GI bleed, it's important to stabilize them first. As he mentioned, trying to find out what the source is good, but ultimately you need a live patient so that you can investigate them further. So important thing is stabilize, then consider investigation. And another way of thinking of it to make it slightly easier, particularly as well for the adults, is to try and think, is it a variceal bleed or a non-variceal bleed? Because the management is definitely different in adult, as Prof. Alp was mentioning. But it also gives you a guide as to what might be the underlying pathology. As you know, with variceal bleed, we're dealing with some hepatic problem, whether it's intrinsic or prehepatic. And when we're dealing with variceal, we're dealing with more of your gastritis or ulcers, etc. So with dealing with knowing how to differentiate it initially helps you treat it better. Patient comes in with a history of painless upper GI bleed, which is quite telling. It's telling you that doesn't have gastritis and it's of acute recent onset. Could suggest maybe varices. Doesn't necessarily mean that, but it could suggest varices. And when you're already thinking it's variceal bleed, and with the history of maybe having patient is jaundice or having pre-existing hepatic pathology, you already direct your management in that sense that you initiate your somatostatin analog early, so that as you know, the octreotide helps quite a lot with decreasing the risk of bleeding in a patient with proven variceal bleed. So initiating early helps with that, versus the other patient who is a non-variceal bleed, so a patient with gastritis or peptic ulcer, where giving somatostatin analog will not necessarily help, but giving a proton pump inhibitor, which generally give a nice big stat dose initially, just to try and actually decrease the amount of erosion, in a sense, that the ulcer is causing in the mucosa. So that helps. So you already in your head know that you are separating them into potential variceal bleed that will need bending, or ones that are bleeding from an ulcer, which is just spurting, and a vessel is just squirting out, that you may have to intervene by giving sclerosing agent, or by giving some adrenaline, which is what some other centers do. So that's the one thing. The important thing as well is, particularly with kiddies, what we usually get is a child who's fresh, like a 6-hour child. The pediatricians call us and tell us that the child is vomiting blood. It's always worth noting how the child was born, how the trauma of the birth process was, because the child could have just swallowed blood. And if a child swallowed blood, then tests that we rapidly don't realize or don't have at the top of our head is something called the APT test, which basically uses the normal physiology of a neonate, or and normal physiology post 6 months, where you know the neonatal hemoglobin is different from an adult one. So this APT test, the one nice thing about it is that you take blood that the child vomited, and you actually you test it on this APT test. And if it's fetal blood, because fetal hemoglobin and adult hemoglobin are different. So generally, when it's fetal hemoglobin, it produces differently and gives you a certain color, like pink or bright red. But if it's maternal blood, which suggests that the neonate may have swallowed the blood, then it changes it into a more brown or rusty color. So these are the tests that are easily available by the bedside that you can actually do to assess where the source of the bleeding is, particularly in a newborn. The other things that we can do with, once you've stabilized the patient, taking them to theater, and now we are in the process of deciding, are we going to bend, are we going to just inject, depending on the pathology we find, is once you see lots of gastritis, you're not sure if it's H.Pylori or other exotic things such as your Zollinger-Ellison syndrome, you can do a urea test. It's called a CLO test, CLO, which is also freely available, which we seem to forget quite a lot. And this is almost like a rapid test to assess if there's a possible H.Pylori that's causing the gastritis, instead of waiting for the histology, which may take some time to come back. So you can literally, all you do is you see the gastritis or inflammation, you take a biopsy, you put it on the CLO test right there and then, and it changes a different color. And once it changes, you know it's positive for urea and highly suggestive of H.Pylori. So these are the avenues that we have at our disposal for that. We generally have a tendency of bending our esophageal varices. We've found that it works remarkably well when we can actually fit our bending scope through the esophagus. This is where sclerotherapy may be of significance or of importance to us, whereby our scope itself is not big enough to fit through the esophagus and allow us to easily bend, whereby then you can consider using our sodium tetradecyl, any sclerosing agent, that you may want to use to actually just inject at the esophageal varices to sort that problem out. The importance of these various staging or scoring systems is just to note that someone who's old, like a 60-year-old patient coming in with the upper GI bleed, they already have some decreased or diminished reserve. So for them to bleed exactly like when a neonate bleeds, a 5 kg neonate bleeds 15, 20 moles, that's significant. It's the same with a 60-year-old male who has a significant bleed. That will be significant because they don't have enough reserve to counteract and to hemostabilize so rapidly. So that's why the older you are, the higher your risk of having further complications. And hence why those nice devices that they have, like the Sengstaken-Blakemore Tube, which is a rather traumatic thing to put in a patient. I've had instances where I've had to put it in a patient who's wide awake and had to have it weighted on the other side while I was trying to stabilize them because there was no other measure at that point in time. But the important thing to note is that you want to secure an airway because you don't want them to vomit, aspirate, and cause further detriment. So securing an airway is important. Then you can consider our Sengstaken-Blakemore Tube, which will temporarily halt bleeding. So that gives you time so that you can further act on these patients. On the algorithm that Voyo put on, at the end, it was not as clear, but at the end, it mentioned our tips, which these are last resort measures in patients whereby you find that you need to kind of shunt them so you can relieve the pressure so that the bleeding might diminish. So these are not, especially tips, it's not a curative thing. It's a temporizing thing until you have a more definitive measure of most likely liver transplant. So I think ultimately the important thing, the gist, if anyone gets anything from this whole talk, is that any upper GI bleed, the important thing is to stabilize them first. Then in your head, try to conceptualize is it variceal or non-variceal. Then institute your management appropriately. And obviously with the history you get, you'll be able to have a slight hint as to which side of the box you can put the patients. Thanks, Prof.
Selo, thank you very much for making things clear, emphasizing and re-emphasizing lots of important points. Can I just invite Dr. Yashoda Manikchand, our other consultant pediatric surgeon? Yashoda?
Yes, thanks, Prof. And thanks, Voyo, and thanks, Prof. Alp, for joining us and giving us wisdom. Just 2 points from my side. For the adults, I think we mustn't underestimate the role of NSAIDs as a cause of a pan-gastritis and upper GI bleed. I myself have had one. But it's an over-the-counter drug and people tend to overdo it. So NSAIDs are a big cause of the upper GI bleeds as well. Then with the kids, with infants in particular, when they're coming with repeated episodes of gastritis, it's important for us to think, I think Sedo mentioned it, of Zollinger-Ellison syndrome or gastronomas. So to do the appropriate investigations to look for that. And also milk allergy gastritis and celiac disease, and there's other sensitivities that are becoming more prominent these days for whatever reason. So that's just my comments. Thanks.
Thank you, Yashoda. That was quite pertinent. I think you and many of our staff will remember we had a child, I think it was last year, a 6-month-old child who had persistent hematemesis, and ultimately we had to send the child to Red Cross, and then they diagnosed milk allergy in that child. So that is somehow becoming common. And yeah, H.Pylori happens in children and it causes serious problems in children. Now I'll just invite Dr. Majola, our third consultant pediatric surgeon, to comment. Dr. Majola.
Hi, Prof. Thanks for the opportunity. Very nice talk, Voyo. Very simplified nicely for our juniors just to understand the topic and very simplified to get just very vast information into sort of just limit those slides just to get the message across. And yeah, I just wanted also to stress what Yasho just said, especially when we're investigating these kids, especially the young ones, where we're really trying to figure out what the cause of the bleeding is, that we don't forget allergy stuff, especially the milk allergies and stuff, and also these kids who are on formula fed as well, because most of the time we never really sure what is inside the formula milk itself. So that's important just to also remember that when we keep doing, or we keep having a child with recurrent bleeds. And as Sila stressed, it's very important, because once you basically channel or in your mind what the cause might be, it's easier to manage that patient, especially after you have stabilized, so that you know the definitive management. A question to Prof. Alp: the patients that they have with varices, are they opting for more on a banding program, or are they injecting with sclerotherapy?
So it's predominantly banding, and for the last probably more than 10 years now, banding has replaced sclerotherapy, and it's usually obviously if the child is too small, as it's also been mentioned here, you just cannot get that banding device, and we still have the injection sclerotherapy as an option to us. But as soon as the child is big enough and the esophagus is big enough to put the banding device through, then we would use banding for them.
Oh, thank you.
Yes, thank you, Alp. I think we also have been doing the same as Selo also clarified. We try and do banding as much as possible, and only in very young infants where the bigger scope doesn't go, then we try and inject sclerosant. I know Dr. Yentl is here, and Dr. Yentl Khamit has spent about 5 years in Baragwanath Hospital. So, Yentl, do you have any comment? Did you do anything different at Bara?
No, I think it was basically the same. Hi, everyone. It's really good to be here. Thank you for having me. Basically the same, just 2 points that I wanted to make on the talk. For you, very well done. And Selo, on the differential or the causes, there wasn't gastric duplication cysts, which I think is quite important in pediatric surgery. And then also in terms of the resuscitation, something that's very topical and in vogue right now is product guided resuscitation, or the TEG. And I think this is also very topical for the intermediate exams, that it's something worth mentioning in the initial resus for the use of blood products, that it should be the ratios 1:1:1, or it should be TEG guided, etc. Even though we don't all have access to those, I think it was just worth mentioning. But thank you very, very much, and well done.
Okay, so I'll just invite Prof. Alp to make final comments before we say goodbye, because then we can finish exactly in 60 minutes. Alp?
Thank you very much. Well, firstly, again, thank you very much for inviting me, and it's a wonderful initiative. And as we were also talking earlier, it's so nice to have the technology available to us. And that's, I mean, if COVID has done one good to us, it's to enable us to come together again on these platforms, and it's been fantastic. And again, with regards to the topic itself, as I mentioned before, as it's been mentioned, it's a very wide topic, and somehow the emergency management of the upper GI bleeding is important, and we need to be very familiar with the steps that needs to be taken. But then the next step is to identify what the problem is, and then have a goal-directed approach. And we've become so used to all these investigations and the high-tech modalities. We must still remember to examine the patient and get the history from the mom as well, and from the dad as well. I mean, we've heard it again in this talk. The importance of the medication that's been used is going to guide you. The simple inspection of the abdominal wall and whether there are abdominal wall varices or not, that signs are there for a liver disease, is going to guide you. And they will form the basis of your treatment going forward, and they're very important. So we just need to pay attention to them. Overall, again, thank you so much for the invitation, Milind, and the colleagues joined us online today. I really appreciate your invitation, and it's been wonderful to spend an hour with you. And we should definitely try to see if we can increase these sort of interactions between different units. Milind, I think is spearheading this. It's really fantastic, and let's see if we can have more opportunities like this going forward. And thanks again.
Thank you all. Thank you all of the attendees. I see there are some attendees from the Department of General Surgery. So thank you very much. We will see you sometime in the future. Thank you. Bye-bye.
Thank you.